Why don't we go ahead and get started this morning? I guess our medical students won't be here because they are taking a test. Some bad planning if we're going to give them medical feedback. Maybe this way we can do it behind their back, as usual. It's a pleasure to introduce Dr. Patrick Nguyen, who is an assistant professor in the Department of Surgery in the Division of General and Laparoendoscopic or Minimally Invasive Surgery. Dr. Nguyen spent the early years of his life after being born in Belgium, and then his family moved to Austin. He is a undergraduate of UT Austin, graduate of this medical school, and a graduate of this general surgery residency. And recently he became the full-time clerkship director for the junior clerkship. Please help me welcome Dr. Nguyen.
All right, good morning. Thank you for the introduction, Dr. Serene. All right, so the timing, it's been poorly planned for whatever reason, but our students are taking their midterm exam, but they actually had to suffer through 2 hours of feedback this year, and from talking to the UME office and the students, they get pretty beat down when it comes to evaluations in their first and second year. So although it's a good talk for them to be involved in, they did get their 2 hours worth this year. So my talk today is on feedback in medical education. I have no financial disclosures. Really, the important disclosure that I have is I don't feel like I have much business talking about feedback in medical education, mainly because it's not an expertise of mine. You know, being a clerkship director, you kind of run the clerkship, you administer the clerkship, you get a good understanding of education. But if you look at feedback in education, it's a very broad topic that's been researched heavily. A lot of the research is done by psychologists. They look at feedback in grades K through 12, college education, medical education. So I've done my best to, over the last month or so, review the literature and put together something that our faculty and residents will be able to use as far as giving feedback in medical education. And this applies not just to the students, but also to resident education as well. So 3 goals to define feedback and its importance in medical education. Let me go to define summative and formative assessments, and then to be able to give effective or develop some strategies to give effective or improve on your effective and constructive feedback. So definition of feedback, if you look at the Webster definition, feedback is defined as helpful information or criticism that is given to someone to say what can be done to improve a performance or product. And really the most important thing here is it's basically the goal of feedback is to improve performance. You know, our students, they see the evaluation process as a part of their grade. You know, the evaluation process for our students is about 26% of their final grade, but the ultimate goal of feedback, both from the learner's perspective and the educator's perspective, is to improve their performance. If you look at the literature that's out there, a ton of definitions, but one that I found that I felt was pretty descriptive is specific information about the comparison between a trainee's performance and a standard given with the intent to improve the trainee's performance. Okay, so again, the goal is to improve. The goal of the feedback process is to improve the performance of the trainee. So a lot of the broad information that I used to put this together really was shared to me by 2 individuals. One is Dr. Erin Nelson. She's a clerkship director for the OB-GYN clerkship, and then the other one is Dr. Christy Kostab, who's the clerkship director for the medicine clerkship. And so I got a chapter out of a textbook. The chapter is titled Feedback for Medical Education. And the very first opening paragraph was pretty powerful. The problem is on a scale of 1 to 10, 10 being too many words for one slide, it's about a 9. And so instead of putting it up on the slide and reading it to y'all, I'm just going to read it to you first, just because I found that when you're sitting in the audience and you've got a slide full of words and someone's reading it to you, you end up just not getting anything out of it. And so I'm going to read it to you. Feedback is essential for learning medicine. It should happen all the time. It seems simple that the more experienced should inform the less experienced about what has been done well or what might be done better the next time. It seems simple that the feedback should be frequent, objective, expected, and timely. It seems simple that students should get such feedback frequently from teachers and that medical educators should be well practiced at giving it. However, feedback remains a significant challenge in medical education. So these are kind of the highlights of that paragraph. And I think everyone realizes that feedback is important. You know, when you look back on your training as a student, as a resident, some of the bigger memories are the criticism that was given to you either in evaluations or in person, or if you had to get called to somebody's office to discuss your performance or some issues, right? So those are the things that stand out, and that's feedback. Okay? The goal of feedback is to inform your performance. If you look back at your medical education, regardless of where you are in your career, the folks that gave you good constructive criticism are the folks that you remember because they actually took your performance and altered it in some way. And then that last sentence is important too. Feedback remains a significant challenge in medical education. I think it is a challenge at our institution. And if you look at the literature, pretty much every single paper that you read about feedback tells you that, number one, it opens it by saying it's really important, and then at some point in the paper, we're not very good at it. Okay, there continues to be challenges in medical education as far as feedback goes. So why am I talking to you about feedback today, right? So the way, for the most part, the way the grand round speakers get their presentation on the calendar is you get an email from Sylvia, Dr. Stewart's assistant. So I got this email way back before October, and she basically gives you a list of dates and asks you if you'd be able to participate in the grand rounds, and then at some point you get asked what your topic is and your CME questions and so on. So I signed up for this date, and initially my plan was, well, I had some interesting cases. I'm going to talk about poor venous gas. Okay? And so, because no one really says, well, I'm going to talk about feedback. You know, it's not really, to me, you know, it is not exciting. It wasn't that exciting putting it together, but it's clearly important, right? So somebody's got to do it. But why me today on February 9th? So the reason I'm giving this talk is really twofold. Number one, the LCME. Number two, the curriculum committee. Okay. When I think back, I've been here for 9 years as a student, as a faculty and resident. I was here for 4 years as a student. I'm pretty sure I don't remember a grand rounds topic being on feedback. I'm almost certain that we haven't had a grand rounds topic on feedback. So why me, and then why you guys today? So the LCME is pretty important. You know, our school went through its LCME crisis in October of 2011. We were placed on probation. It made the newspapers, and it was a big deal, and everybody in the dean's office freaked out, and then the rest of the faculty body had to suffer through 1 million committee meetings. You know, there are a ton of committee meetings. And the reason it's so important is if you're going to go to medical school in the U.S. and your school is not accredited, you can't sit for step 1, you can't sit for step 2, you can't enter a GME program, you can't get financial aid. So it's important to be LCME accredited. And it's also a matter of pride, right? We don't think of ourselves as a bad medical school that does a poor job of training students, and that's why we got put on probation, because we did a poor job training students. That wasn't the case. If you look at the time, there are 126 standards, and the data we were given is basically whenever a school undergoes LCME accreditation, for the most part, on average, there are going to be about 6 to 7 standards that you're deemed not acceptable on. And so for our institution, we had 10, and that was enough to get on probation. So it's not that we had a horrendous program, it's just that we were above average in terms of not meeting acceptable, and in our case it was 10. The average is 67, 6 to 7. So that's and then the other thing is, if you look at the EDs or educational directives, there's about 8 to 10 educational directives that apply to the clerkships, to the third year education of our students, and 4 of those 8 to 10 basically talk about assessment. Okay, so talk about feedback is a form of assessment. Feedback is a formative assessment. So clearly important in the LCME eyes, and we were not dinged on assessments. This is just to give you an example of, again, it's critical to the education of our students and residents, the feedback process is. And then lastly, you know, when somebody tells you what to do and then they're in a position of power and what they're telling you makes sense, then you just have to do it. So the curriculum committee, they meet annually. One of our big weak points was that there was no central oversight of the curriculum. Okay, so the UME office reorganized and they developed a very robust curriculum committee, and that curriculum committee is basically responsible for reviewing every single year of the medical school, assessing it, assessing that year, and making recommendations and so on. So this year, one of the recommendations for the Department of Surgery and the Surgery Clerkship was faculty should receive development on useful, specific feedback driven by learning objectives, whether via discussion by the UME office or identification of resources separately. So I'm that separate resource for you guys today. I'll be the separate resource. So basically, it is deemed important enough that the curriculum committee said do it, so that's why we're doing it today. So to understand why feedback is important, as I reviewed this, basically there are two types of assessments. There's a summative assessment, formative assessment. And it took me forever to truly understand these two, even though maybe it sounds simple to you guys, but when I read stuff, you know, you're used to reading clinical stuff, surgical stuff, operations, procedures, surgical diagnosis, whatever. You know, I don't dabble in feedback research until now. And so summative assessment, just 2 slides on summative assessment, because summative assessment is not really feedback. Feedback is a formative assessment. So summative assessment is 3 different definitions as I reviewed the papers on this. It is assessment of learning. It's used for promotion and certification. It's the gathering of information at the conclusion of a course or program to improve learning or to meet accountability demands. That's how summative assessment is defined. It was still confusing for me, so I used Google. All right. And once I found this website, Carnegie Mellon Institute, their definition was way easier for me to understand. So basically, the goal of a summative assessment is to evaluate student learning at the end of an instructional unit by comparing it against some standard or benchmark. These tend to be high stakes, which means they have a high point value, and then they give some examples. So examples on the surgery clerkship, this is one of those CME questions for the faculty. We've got weekly quizzes, the OSCE exam, the midterm exam, the NBME end of clerkship shelf exam. Okay? Just to throw you for a loop, any of these summative assessment tools can actually be used as a formative assessment as well. So on the LCME forms, when we filled them out, they asked what kind of formative assessment tools do you have, what kind of summative assessment tools do you have. So we actually put down our weekly quizzes as formative assessment tools, because the students take these quizzes, they get the answers back right away, and then based on their performance, they use those answers to direct their learning. So that the quiz can serve as a formative assessment. AppSite exam or your mock AppSite exams can count as a summative assessment. If you're using the mock ones as a learning tool, then you're also using it in a formative fashion. All right, so formative assessment, assessment for learning. It has a priority intention of improving performance by making an assessment of how a student performs on a task and then providing feedback to the student about how the performance can be improved. And the Carnegie Mellon description on their website wasn't quite that helpful, so I didn't put it up here. But really, the big picture for a formative assessment tool is to enhance learning or to improve the recipient's performance. And these are very important to understand that. Whenever we complete evaluations, whenever we give feedback to a resident, a student, informally, immediately, then the goal of that is to, as you're doing that, it should be to enhance their learning. It should be to improve their recipient's performance. And I think everyone gets that. I mean, when we're giving feedback at the bedside or in the clinic or in the OR, you're really doing it for the most part to improve performance. Maybe once in a while, a very small minority of individuals may have different goals in feedback, but for the most part, it's to educate and enhance learning. So on the surgery clerkship, we have two formal formative assessment tools. One is a mid-rotation evaluation. Really, the faculty members will be familiar with that one, not the residents, because for us, it's an LCME mandate that students get mid-clerkship or mid-rotation evaluation. Whether you're a 4-week clerkship, 6 weeks, 8 weeks, it's a mandatory thing that a formative process is in place. Really so that a student can self-assess and the educators can assess the students, and then they have time to improve on that. Versus they go through 8 weeks of surgery, no mid-rotation evaluation, who knows what kind of feedback is given. They get their end of clerkship evaluation and then they failed and they're like, oh, I didn't even know I was supposed to do this or that, whatever. Okay, so that's basically the oversight says you must do this, and so and because they have good evidence to say that it works. Formative feedback does work. And so that's why we do it, because it does help our students. And really, maybe it doesn't, the top students, the above average students, maybe it doesn't help them because they're going to self-assess themselves and do what they need to do to improve. But the struggling students may not have the insight as to what they need to do better. And so they could go on struggling through the entire third year of medical school, become 4th years, and then all these issues become evident. So that's a mid-rotation evaluation. They self-assess and complete a form in 12 categories, self-assess their overall performance, have a sit-down or stand-up with a faculty member, and then submit that to the clerkship office. And then you've got the clerkship clinical performance evaluation. At the end of each 4-week rotation, there's 2 of them total. The faculty, the residents, the interns may complete a end of clerkship evaluation on the student. And if you look at the categories, they essentially match up to the ACGME competencies. Okay, about 2 or 3 years ago, the UME office wanted every single clerkship to develop a unified evaluation tool. They wanted the tool to be the same because back then there are 8 separate evaluation tools for the 8 separate clerkships. And so we decided to do it in the same categories as what the students are going to experience in residency. So the core competencies and professionalism. And then these are mandatory responses. We want you to include comments on the strength and areas needing improvement, and describing specific behaviors and skills that were observed, and including comments on professional behavior if improvement is needed. All right, so the purpose of feedback. So again, remember, the most important thing really is feedback is to enhance learning. We'll say that a few times. Feedback is to enhance learning. The purpose of feedback is to document adequate performance and progression. From the big picture standpoint, the purpose of feedback is to affirm the achievement of the competencies required for medical school graduation, or in the case of residency education, for GME program completion and independent practice. And in the GME setting, you've got terminology such as milestones. In the undergraduate medical education setting, you've got terminology that's fairly new, but entrustable professional activities. What should a student do by the time they graduate? Entrustable professional activities. And so how do we ensure that our students are achieving these milestones or these EPAs? Basically, the evaluation tools is one important aspect of it. Although I'm not going to touch on it that much here, it's important to state that when you're giving good feedback, an important part of giving good feedback is having established goals and objectives, and establishing at the beginning of a rotation what your goals are for the students, what they're expected to do, so that when you sit down with them and do their evaluations, or when you give them informal feedback, there's something that they're supposed to strive for. Okay, so it's important that when you're completing evaluations, you're doing it based on goals and objectives. And so our school has a set of goals and objectives, and basically is broken down into altruism or professionalism, knowledge, and skills. And if you look at the terminology, each category is stated as, by the time of graduation, a medical student will. And with part of the LCME oversight issue, our UME office now is very big on being able to map out everything that happens. They want to be able to map out everything that happens in the medical school. So they want to be able to pull up any of these objectives and competencies and then identify exactly where in the 4-year curriculum it's taught. And how do you assess it? What assessment tools are being used for every single one of these objectives? And so Ross Willis and I are in the process of basically, one of the other to-dos was please redefine every single goal and objective you have on the surgery clerkship in exquisite detail and map it out to these objectives and competencies and map it out to some kind of assessment tool. And so we'll be in the process of doing that. But essentially we send out the goals and objectives as a mandatory part to all the faculty, residents, interns once a year, and they're also available on New Innovation. But I can tell you that very few people look at those. You know, raise your hand for the residents. Raise your hand if you even know there's goals and objectives for every rotation. Transplants got them, so you know about them. Raise your hand if you've actually read them when you start a rotation. So that's no one, right? So it's a lot of effort. No one's read them, except for Dr. Dent, Ross Willis, other program directors, and then whoever had to write them, right? But no one seems to read them, right? And maybe it's because ours, for the student standpoint, maybe it's because they're not user-friendly as defined by the UME office. So hopefully, in the next few months, we'll have user-friendly goals and objectives that someone will consider opening in the future. All right, so the purpose of feedback from the learner's perspective, it's an important tool to cultivate the learner's ability to self-evaluate. It provides, I mean, it's basically constant practice, right? Somebody tells them, you're not that great at doing a history and physical, you keep leaving out important aspects of the patient's history. For example, you didn't ask about the surgical history in a patient that presented with nausea, vomiting, can't have a bowel movement, can't pass fluids. Okay, and the students will self-assess and they'll say, well, you're right, I'm not very good at that, I'm going to improve on that. Or they'll be in denial and say, oh, I think they're full of it, who cares about past surgical history, irrelevant, we're going to get a CAT scan, it's going to be fine. So it's constant practice. You know, you self-evaluate, how am I doing? Am I doing this well? Am I not doing this poor? Am I not doing this well? And then you've got residents and interns and faculty members that are then assessing you, and you can compare yourself to an external assessor. It also helps build confidence over time. You know, if a student is routinely being evaluated on their history, skills, physical exam skills, ability to develop a diagnostic plan, and identifying a critically ill patient. Over time, it builds the level of confidence that they need to eventually be interns, residents, and independent practitioners. We're not going to talk about this much, but you've got formal versus informal feedback. Formal would be, for example, the 2 evaluation tools we talked about. And informal is just the day-to-day feedback that we receive when we're working with faculty members or senior residents and so on. Immediate versus delayed. Clearly there's in the literature, immediate feedback, immediate brief feedback sessions or have a bigger impact on performance than delayed at the end of my clerkship 6 weeks later. Overly too long evaluation tool. So delayed and too much detail is not as effective as frequent small pieces of feedback. All right, so how about feedback and its impact on performance? It's actually hard to measure the impact of feedback on performance. It's easier to measure the satisfaction with the feedback, harder to measure the impact on performance. So a number of factors go into it. The feedback it's got to be good feedback. So it's got to be specific and actionable. It can't just be good student, good resident, did well. And we get that a lot, unfortunately. Okay, but it's got to be specific and actionable. Otherwise, you really don't have anything you can get better on. If somebody says you did a good job during your 6 weeks on transplant, that's not quite as helpful as you know, you need to understand the hepatobiliary anatomy better. You need to read up on it, or you need to understand the steps of a Whipple better. So it's got to be specific. It's got to be actionable. It's important that the learner understands and accepts that feedback. Okay, and so that's why the School of Medicine decided that one of the longitudinal sessions for the students was going to be a 2-hour session on feedback, how to give it, but also how to receive it. Learners got to be motivated to change, and then the learner has to take action. So these are factors that some of the factors can be controlled by the person giving the feedback, but others are completely out of the educator's control. And then as far as satisfaction with feedback, there's an article that looked at the AAMC graduation questionnaire. And for some of the core clerkships in the 2012 questionnaire, as many as a third of responding students did not agree that faculty provided sufficient feedback on their performance. As far as the 2013 ACGME resident survey, they found that satisfaction with feedback after assignments had the third lowest rating among the 41 items used to assess GME programs. If you look at the San Antonio data, and I only have the data for the students, but it's older data. For whatever reason in 2014 they didn't ask this question anymore, so I only have 2010 data available. But in 2010 for the surgery clerkship, for the question or statement, faculty provided me with sufficient data on my performance. If you look at all respondents, all schools in the U.S., about 19% disagreed with that statement. At our institution for 2010, it was about 13%. So not quite as bad as the up to a third in certain clerkships don't provide sufficient feedback. It seems that for the surgical clerkship, we're actually doing better than the national mean for those that disagree with us providing sufficient feedback on performance. All right, so if you look at the literature, there's actually some discrepancy between those giving the feedback and those receiving the feedback. So this study was done at McGill University in Canada, and their goal was to implement, they were going to implement a workshop on feedback. And so before implementing the workshop, they wanted to assess, you know, their program. What do our residents think about feedback? What do our faculty think about feedback? And it seems that the faculty and the residents didn't agree on much when it came to feedback. So for the statement, feedback was given often or always, immediately after the fact or activity. 86% of the faculty member felt that they did that, whereas only 12% of the residents. As far as the feedback that's given to the learner is based only on behavior that was observed directly by the faculty. 85% of the faculty felt that that was the case. Only 54% of the residents felt that that was the case. 4 other things that they didn't agree on. Okay, 69% of the faculty felt that the feedback they gave was complete and incorporated all aspects of the performance, versus only 16% of the residents. 96% of the faculty felt that they gave concrete suggestions for improvement, versus 13% of the residents. 97% of the faculty felt that they allowed residents to react to the feedback that was given, versus only half of the residents. And then 90% of the faculty felt that the feedback they gave was non-judgmental, versus 41% of the residents. So there seems to be a discrepancy between the learner and the feedback giver. And perhaps that's what's driving the dissatisfaction with the feedback. All right, so things that they did agree on. They did agree that follow-up is never or seldom arranged to verify that the feedback was received or implemented. All of them, the surgeons and the learners, agreed that surgeons are very comfortable giving negative feedback. And then residents are never or seldom asked what they wish to receive feedback on. So clearly the teachers and learners differ in their perceptions on how feedback is given and received. And this is kind of the driving point towards having development on feedback. And the development needs to be both ways. The learners need to get some faculty development on how to give effective feedback, and then that was the teachers, and then the learners need to understand how to receive feedback and what it's meant for and how to incorporate it in your learning. So some theories as to why there's feedback failure. Faculty lack the necessary skills. There's not much time allotted for the activity. The supervisors, based on how the learning environment is set up, perhaps the supervisors have inadequate contact with the students or inadequate opportunities to directly observe the students. And then lastly, the learners aren't well primed to receive the feedback or even accept it, and some may just deny the feedback, okay? Particularly if the information is critical in a negative sense. So that implies that maybe we need to phrase the feedback a little bit differently, okay? Now, a couple studies. Feedback is better than praise. This is common sense. It's interesting that you can do this study and get it published. But basically, they took early years medical students and were basically taught them two-handed knot tying technique. And they had two groups. In one group, all they did was praise the students. Okay, didn't give any kind of criticism or feedback. All they did was praise the students. And in the other group, they gave constructive feedback on how the student could improve. And it's really not surprising that the performance was better in the group that received constructive feedback. And also not surprising that those who received praise were more satisfied with their feedback versus those that received constructive feedback. So that's a common sense one. Positive framing of criticism results in better performance. Different study, they took first-year medical students learning how to use the Weber-Renée tuning fork procedures on standardized patients. And one group got standardized to positive framing of negative feedback. And then the other group basically received negative framing of the negative feedback. Okay, so positive framing, you did this well, here are some tips where you can improve. Negative framing, you didn't do this well, you should change, etc. And they found that the subjects in the positive framing group of the negative criticism were actually more satisfied with their feedback, had higher self-efficacy or self-confidence scores, and their performance was improved compared to the students who received the negatively framed feedback. Their performance improved both immediately and then when they brought the students back 2 weeks later. So how you frame your feedback, whether it's the immediate feedback or the delayed feedback in the evaluation process, is important. So that's essentially the sandwich feedback technique. And there's other terminology. If you Google sandwich feedback technique, there's another 4-letter S-word feedback technique that shows up with interesting images. So this is a cartoon that was pretty funny. This was the highlight of my talk. So I showed this to my 5-year-old, and she's starting to learn how to read. So she now knows this saying. We'll see what happens at school today. All right, so this brings us to the last part of the talk. I've got these little feedback cards, if y'all can pass them around. And I asked Kalia, our academic coordinator for the clerkship, to basically make them pocket-sized. All right, and these are from Johns Hopkins. So it's well vetted. And from the stuff that I read about feedback, everything that's said in these cards apply. Okay, so rather than coming up with my own fancy card, I figured I will use the Air Jordan approach, right? If you're playing basketball and you're wearing your Jordans, you can maybe hustle a little more, jump a little higher, and then play better. So now that you've got a Johns Hopkins feedback card, that might work for us. So, and essentially I'm just going to go through the card, and then we'll finish things up. So good narrative comments. Okay, we have all sorts of examples of narrative comments. Even though it's a mandatory box, somehow there are times where there's nothing that shows up in there. So somehow y'all are hitting the space bar or something, but the mandatory box is not working for some evaluators. So good narrative comments are going to be constructive, concise, specific, and actionable. Okay, specific was used in one of the definitions on feedback. And again, remember, as you're filling out these evaluations or as you're giving feedback on a day-to-day basis, it's really, the goal of your feedback is just to enhance learning. All it is to improve performance. Reviewing the learning objectives and desired competencies for the rotation. And, you know, it is a task to read through all that stuff. Where can you find it? You can find it on New Innovations. This is New Innovations if you have not checked it out. But all our faculty members and residents and interns should have access to New Innovation. And so both the students' goals and objectives and also the residency goals and objectives for all the rotations are going to be on there. Remember the feedback sandwich, okay? Do you have some, what is the student or learner doing well, and then what can the student improve on, okay? Positive framing of criticism appears to work better than negative framing of criticism. Different modifiers that you can use, okay, consistent, reliable, making progress, or if it's the opposite, so-and-so is not consistent, not reliable, not making progress. And then giving examples, okay, giving examples is important. That way the learner can see that it was based on direct observation what the negative criticism might be. Avoiding vague and global statements such as great to work with or good student will make a great surgeon. Although it's nice, you know, you can use that as the praise, that alone is actually not going to help someone improve their performance. Even if they're already outstanding, even outstanding individuals can improve. So important to not use just global statements as when giving feedback. So on the back side of it, the groundwork, when you're ready to give the feedback, important to even set the stage. So at the start of the rotation, give your expectations, goals, and objectives, what you expect them to do. Let them know to expect feedback. And then when you do give the feedback, open it up by saying, let me give you some feedback, or let me tell you what you can do better. Okay? We've got one faculty here that's extremely good at opening or setting the stage for giving negative feedback. Okay? And so the way it usually works, and y'all are going to be able to guess who it is. Usually the way this individual says, let me give you some feedback, usually it's going to be, I meant what the, right? Y'all know who that is? I meant what the F, Dr. Serenity. Okay? Huh? Yes, what the fine? What the feedback? What the feedback? And so what the feedback, it actually works quite well, right? You know for a fact when you're about to get what the feedback from Dr. Serenity, it's going to be criticism on your negative performance and guaranteed that you're not going to do it again. Guaranteed, right? And so through the years, I can't remember if I've been a recipient of what the feedback because I've heard it too many times, right? So, because I can't remember, was it me or was it the student next to me or was it when I was a student, was it the chief in the case getting what the feedback? But you freaked out. You know, Dr. Serenity, you have freaked out a lot of visiting fourth-year students, you know. When you talk to the students, they'll like tell these stories, man, I was in the OR and Dr. Serenity just went off and, you know. So what the feedback actually works quite well because you know exactly what you're going to get when it's prefaced. What's that? Weeding out the wheat. Those that can't stand the feedback will not survive. So that's how you prepare for your feedback meeting. Organize your thoughts and observations. Sometimes it's appropriate to do it in a group setting. That way the whole group can learn from how you can present better or how you can gather appropriate data for coming up with a diagnosis and plan. Other times it's better to do it in a quiet setting, one-on-one with the student. And then the rest you can read for yourself. And remember, frequent feedback. Limit the feedback to no more than 4 areas. And then assessing the learner's perspective. What do you think you did well? What do you think you can improve on? Giving the feedback, what do you think you're going to do to now improve on this performance? And with that, I'll take any questions or comments. Yes, sir.
Make a few comments. This is an area that I was very involved with. During the time when Dr. House was running the department, he kept for himself the official title of being in charge of medical student education, because he felt it was symbolically important to say the chairman cared about medical students. But he in fact delegated all that to me. So I did everything that had to do with medical school education at the department. I also had a job in the dean's office, which among other things had to do everything with the LCME. Mm-hmm. I prepared the evaluation, etc., and I'm glad to tell you that we were never put on probation. I was involved in that, and in fact were regularly praised. And I spent 8 years as a member of the National Board of Medical Examiners, which also has something to do at the national level with the public at hand. But I'm going to confine my remarks to your specific topic, feedback of medical students. The official line is, on the part of the LCME and everybody else, you got to improve, therefore you have to be critical. In fact, at the level of the accreditation of a medical school, if your medical school just found out the cure for cancer and 2 faculty members got Nobel Prizes, you could not, in your LCME statement, say, we're doing fine. You were supposed to say, we're very proud of the 2 faculty members who got Nobel Prizes, but we realize we haven't done anything about heart attacks. So now we're going to work on that. Well, when it comes to the student feedback, I think you have to balance criticism with praise. Although the official line is it should be criticism so they improve. Human nature is such that if all you do is tell the young trainee how bad that person is, that young trainee is going to be discouraged. So you need to balance the official criticism with a little bit of praise, and it can be done.
Right.
So that's the only comment that I would like to make.
Thank you. Yes, sir.
That was really great, a great talk. I wish I heard that 30 years ago. Maybe I did. But I want to thank Dr. Pastana, because I thought that was my own personal experience, all the negative feedback. I thought it was just me. And saying what the feedback, historically, the worst feedback you could get was a whack on the head with a Harvard ring by one of our esteemed faculty members. I think corporal punishment is out at this point.
It is out for sure. All right. Thank you all for your time.
While we have a moment before we start M&M, everyone has spoken at the during the ABSITE for the election of the new administrative chief residents, and the results are in. Yes, so y'all have selected taller versions of Liz and myself. Travis and Ashley are the new administrative chiefs.
I don't want to be critical.